A very good afternoon to everyone present here. Today our lecture topic is Myasthenia Gravis. First of all, may I introduce myself? I am Arvind Silvermaster, Professor Department of Pharmacology. What is the Myasthenia Gravis? So, what is the Myasthenia Gravis is a chronic autoimmune neuromuscular disease. So, how the neuromuscular disease can be accumulated in the our gene that the muscles weakness and rapid fatigue in our voluntary muscles. So in that, the diagram shows as a normal healthy muscles and the myasthenia gravis muscle. In that normal muscles, the nerve endings and then neuromuscular junction and receptors, the junctions and receptors, there is a very normal function, and then the normal signal transmission is produced in that neuromuscular junction, and then the strong the muscles contraction is very strong, and then myasthenia gravis muscles, they have a very damaged neuromuscular junctions and then blocked with the acetylcholine receptors and reduce the acetylcholine level in the muscles. They have a produced impaired signal transmission to the muscles fatigue. There is a disease, myasthenia gravis. What are the pathophysiology involved in that? The autoantibiotics attack the nicotinic acetylcholine receptors at the neuromuscular junctions. They reduce the available cytokinin receptors, impact the neuromuscular transmission, that results in the progressive muscles weakness in the normal and myasthenia gravis muscles. Then what are the clinical features in myasthenia gravis? That's a ptosis, and then the ptosis means of dropping eyelids and diplopia. So diplopia is a double vision of the patients, and then difficulty in the swallowing and speaking, and limb weakness. The muscles we already weak in the myasthenia gravis, so that the limb also weakening in the the limb weakness also present there, and then symptoms worsen with activity and improve the rest. Improve with the rest. And then what are the treatment goals of myasthenia gravis? To improve the neuromuscular transmission and then suppress autoimmune response to achieve the remission with the minimal side effects. So in that anticholinergic drugs, there is a symptomatic treatment where the mechanism of action of the acetylcholinesterase to inhibit the acetylcholinesterase enzyme. In that acetylcholinesterase, involved in the synthesis of acetylcholine synthesis to block with the acetylcholinesterase enzymes to increase the acetylcholine at the neuromuscular junction to improve the muscle contraction. So that the drug of choice is first line drugs for the myasthenia gravis is 5-dose. The dose of the 5-dose is a 60 to 20, 120 mg for the every 4 to 6 hours orally, and then the longer duration of action to be produced and better tolerated with the fewer side effects, and then provide symptomatic relief only. So then next drug is neostigmine. In that neostigmine, the dose is 15 to 30 mg per every 22 to 4 hours. There is a drug of action is a very shorter acting, and then used for the diagnostic testing only. And then what are the side effects to produce the anti-cholinesterase drugs? In that muscarinics, they produce the abdominal cramp, diarrhea, and increase the salivation and bradycardia and nausea. In the nicotinic receptors, they have a produce muscle vasculation and then cramp. In that management, how to manage the side effects to atropine or propandolene or muscarinic to for the muscarinic effect. So, what are the limitation? The dose does not modify the disease progression. They only for the symptomatic control. And then immunosuppressive therapy is a long-term control. The what are the immunosuppressive therapies are there? The first one is corticosteroids. In that corticosteroids, the drug example for the prednisolone or prednisone. The most commonly used dose of the starting dose is 15 to 25 mg per day, gradually to increase the 60 to 50 to 60 mg per day, and onset of action is 2 to 4 weeks, may cause the initial worsening before the improvements. And what are the side effects to the corticosteroids? They produce the weight gain and osteoporosis, then hyperglycemia, hypertension, and infection. And second category, steroid sparing agents. In the steroid sparing agents, drug example for using the this category azothiophyrine, and then the dose is azothiophyrine is 2 to 3 mg per kg per day, and onset of action of azothiophyrine is 6 to 12 months, and they are acting a very slow acting and allow the steroid dose reduction. So how they monitor the level of dose reduction is a CBC and liver function test, and then cyclosporine, mycophenolate mofetil, and then mycophenolate mofetil is a dose is 1 to 1.5 gram per twice daily, and then better tolerate and faster onset of onset than compared to the azithromycin, sorry, azathioprine. And then cyclosporine, in that cyclosporine dose is 4 to 5 mg per kg, and then the drug is fast acting to the 1 to 3 month duration of period, and then side effect is nephrotoxicity, and then nephrotoxicity and hypertension. So in that video, we have to discussing what is myasthenia gravis and what are the pathophysiology involved in myasthenia gravis, and then what are the treatment process involved in myasthenia gravis. The main treatment process is first one is acetylcholinesterase enzyme inhibitors, and then immunosuppressant therapy. In that immunosuppressant therapy, we have used for the corticosteroids and then other steroid drugs. They focus only for that normal. We have to focus only the disease is a autoimmune disease, so that we are focusing that area of immune response to improve our immune response, and as well as our still muscle weakness. We reduce the muscle weakness of the fatigue in the smooth muscles of the our body, so that we are focusing acetylcholine. Acetylcholine is a receptor. Acetylcholine is a neurotransmitter to produce the contraction of the muscles in our body. So we focus on that video where what is the myasthenia gravis, what are the difference between myasthenia gravis and the normal healthy muscles. In that neuromuscular junction, they have a very longer active with the longer act with the um, muscle fatigue is the present there. The drugs to block with the neuromuscular acetylcholinesterase enzymes, so that the acetylcholine is the conversion process is stopped, so that the acetylcholine produce the longer acting effect in the myasthenia gravis. So that our in that video we have to focus how the management to treat the myasthenia gravis, how to treat the drug of choice of myasthenia gravis. In the first line, drug of choice is acetylcholinesterase enzymes inhibitor, and then second category of treatment is steroid drugs. That is a immune suppressant agents. In the immune suppressant agents to produce the many steroid drugs involved in that myasthenia gravis treatment. The first one is corticosteroids, and another one is other immunosuppressant drugs. So that we conclude the video. Thank you.